Good morning, everyone. My name is Bhumika, and on behalf of the Healthcare Club at Harvard Business School, Olivia and I would like to welcome you to the 17th Annual Healthcare Conference. We're really glad that you braved this cold weather to spend your Sunday with us, and we hope that everyone will have an engaging day. While we were planning this conference, we really wanted to expand the scope of healthcare from the four walls of a clinic to talking about a person's health holistically. And Atul Gawande's line from his book, Being Mortal, stood out most with us. He said, "Medicine's purpose is narrow. Medicine's purpose is repair of the body, not sustenance of the soul." And that brings us to today's theme, from healthcare to whole person care. Even though we spend more than ever on healthcare, outcomes lag behind targets. We need a comprehensive approach which treats a person holistically, addressing the socioeconomic, behavioral, and mental aspects with physical and mental well-being. Keeping that goal in mind, we have tried to plan today's activities, trying to address how we move from patient to person with the ultimate objective of improving quality of life.
Thanks, Bhumika. One of the things I've learned as a student at Harvard Business School is to respectfully challenge the status quo. So, to put that into practice, we're asking all of you to be constructively critical about our healthcare ecosystem today. And furthermore, we ask you to think about how you can be the change that you want to see in the world, whether that's big or small. In that same vein, we ask that you ask respectful, thought-provoking questions to our speakers. To do so, you can download our event app. It's called Whova, that's WHOVA. Quickly make a profile, search HBS to find the event. The code is HBS 2020 HCC. From there, click on the session where you have a question and add a comment. Someone from our team will then curate the questions and give them to the moderator during open Q&A. With that, I would like to introduce our opening speaker for the morning. Her name is Regina Herzlinger, and she is the Nancy McPherson Professor of Business Administration here at Harvard Business School. She was the first woman to be tenured and chaired here at HBS, and the first woman to serve on the board of many established companies and startups. So please join me in giving a warm welcome to the woman known as the godmother of consumer-driven healthcare, Regina Herzlinger.
Thank you. What a great honor to be here, and what a great honor to see all of you. 17 years ago, I think we could have filled this conference in a little cafe. So I'm so thrilled that times have changed. Before I get started, I'd like to thank these two for the amazing job you did in organizing this conference. Kudos to you. So I'm going to introduce our distinguished speaker, Javier Rodriguez, who is the CEO of Davita. Davita is a Fortune 500 company and one of the two leading companies in the world that handles kidney dialysis. This company, Davita, has a long history with HBS. Javier, we are lucky enough to have him as an HBS graduate. Preceding him was Kent Theory, also an HBS graduate, and I knew Kent. Kent was my student. I was on the board of the company that preceded Davita. It was called Total Renal Care. What a name, right? So Total Renal Care was organized by another HBS alum. His name was Victor Chaltiel. Victor understood that the field was very fragmented, and he rolled up a number of independent dialysis facilities to bring economies of scale to them. Great visionary. Execution, not so much. So Davita stock was up in the sky, and then it fell to $1 a share. The investment banker on the board, of course, wanted to buy the company, and I wound up, by some stroke of good or bad fortune, as the chair of the company, and I recruited Ken Theory, to which I'm owed a great deal. Ken Theory, if any of you know him, is just a brilliant CEO, built the firm up. But boy, you don't want to negotiate with him. I spent 3 months, I actually lived in Chicago, negotiating the restructuring of what became this great firm of Davita. Victor Chaltiel came from a company called Baxter, for which you also worked, Javier. Baxter made dialysis filters, was another firm that was heavily influenced by HBS graduates and brilliant visionaries about transforming this field. So what is the field about? Kidney dialysis is about kidneys that don't filter. People died. Kidneys stopped filtering and people died. In Holland during World War II, there was a brilliant Dutch physician. His name was Willem Kolff. And in the middle of World War II, he cobbled together the first dialysis machine. He made it out of a wash tub that he got from a washing machine, a mower, an electric engine that he got for a lawnmower, and the filter was sausage casing with holes poked into it. He killed his first 12 patients. They would have died anyway, but probably he killed them more rapidly. But he saved the 13th and a number on. He kept refining this machine. Willem Kolff, like many technology entrepreneurs, was an iconoclastic man. He was strongly advised to leave Holland. People said to him, somebody as crazy as you is never going to succeed in Holland. There's only one country that will accept you. That country was the US. That is how the deal with Baxter was structured, and this wonderful connection that this great school is lucky enough to have with this great industry and this great company began. So, Javier.
Thank you, Reggie. Thank you, Reggie, and good morning, everyone. It is a pleasure to be here. When you hear the introduction of the godmother and you're in this kind of forum, all of a sudden you say, gosh, maybe I should have practiced more. I have to say something smart. Because partly my son Alexander's here. He's a sophomore at Boston College. And there was a big draw to coming back and talking to you, and there was a big draw to seeing him, and seeing him was really fun, so then the homework was a little on the lagging. But when I saw the header of the conference, it just really sung to me, so I said, I really want to partake in that, so thank you for having me. The very first thing that I thought of when you asked me to speak is, wow, HBS. I remember there 22 years ago, sitting in those steps, nervous as all get out about my job. What should I take? It's 1998. It is the first time that HBS is going to have more graduates go west than investment banking and consulting. Literally the first time in its history. The internet is taking off. The markets are heating up. And I'm going to this company that Regina referred to as Total Renal Care. My buddies couldn't remember the difference between renal and another word, and they would say, you're going to work where? And they would use different parts of the body, sometimes offensive parts, just to make a point. They said, I thought you were smart. And so, when you're leaving and all these really smart people are questioning you, you do doubt it. But I was here with my wife, Jody. As you can see, not high-def pictures. You need to carry a camera back then. There was no phones. But I remember meeting with a Professor Thomas, and I went through my offers, and I said, I've got 3 very good offers. How should I make this decision? I've got all this student debt, and all these rich people keep telling me not to worry about debt, but I don't feel rich, and I'm worried about the debt, and my wife's pregnant, and I've got all these life decisions. And he said something very simple, and he said, where do you want to make your mark? And then when I started thinking about that, and it really dismissed the other two, because healthcare was the only one that kind of spoke to me, because it had some real issues that spoke to me, to my heart. And I said, at one point or another, we're all going to be consumers of healthcare, and I'm just very dissatisfied with the way it's delivered. So that's at the heart of your conference today. 22 years later, the questions are still deep, if not deeper. The challenges are more robust, and the connections seem to have not worked. So all those questions are still at the heart of the conference. So what I'm going to try to do today is tell you a couple of my views and how our company is doing it, so that we try to be as useful as we can. Let me start with the advancements of healthcare. I'm going to leave it super high level because I want to talk about other things, but I do think, and I'm very frustrated about the fact that most of the time that healthcare is spoken about, it's to critique it, right? As there are very few times where I go out and say, man, look at this advancement, look at this innovation. You go from a tub where we were killing people to an amazing technology that can be done in your home, at bedside. We should be talking about that. We should be talking about the fact that people get to live a lot longer, and that healthcare, while is not as convenient as ordering your Uber, it's getting a lot more convenient. But instead, it feels like most people talk about the challenges. I don't know if you saw the USA Today yesterday or Friday, the headline, "Healthcare is sick." That's the front page. Kind of catchy. Healthcare is sick. And then you go through it, and it just goes in theme after theme after theme, and just totally talks about all the issues. In particular, it talks about cost. Who should bear the cost? What's innovation? It goes into some of the difficulties on end of life and some of those issues that we're wrestling with. And the reality is, I don't think you're going to go in the conference today or any session where you're going to find a diagnostic that hasn't been spoken of. I think actually too many people continue to point to the problem. What I'm encouraged is that I see this beautiful auditorium filled with brilliant young minds that are going to change this. I need all of you to start to say, am I pointing to the problem, or am I focused on the solution? And I'm going to give you a different hypothesis as to all of those reasons that have been cited as to what's wrong with healthcare. And that is not my family, not what you were expecting, right? I'm going to make my hypothesis through a very simple story. This is my family. There's 17 of us. This was taken 2 months ago. My dad's 80th birthday is actually on Tuesday, this Tuesday. But we couldn't get everybody down to Mexico, so during the December holidays, we said, Dad, can we celebrate you? Why do I think my family is like healthcare? When you ask my family, do you want to go to a restaurant, what do people say? Sure. Where do you want to go? Wherever. Okay, let's go Italian. Well, I had Italian yesterday. All right, let's go Chinese. Not feeling like Chinese. Well, then it's not whatever, okay? I mean, I just gave you a couple of things. Do you want to go to a movie? Sure. Not in the mood for that one. So we just blob through decision making. And by the end, you're like, you know what? We passed the dinner time. We missed the movie, so we're sitting here. All right? So that frustration and that energy for someone like me that gets to make decisions every day, all day, and just kind of say, hey, do this, and it gets done, is infuriating. Okay? So I'd sit there, and finally I just started to say, I just can't take this. And then my brother-in-law, who's also an executive, put the name on it. He goes, are you frustrated at the amoeba? So that's the term that started to be referred to. I actually don't even know if scientifically it makes any sense. But forget that for a second. We adopted it. It's sort of a blob that just kind of goes without leadership, and it breaks into parts, and then it kind of comes back together. I'm here to tell you that that analogy actually works for healthcare. That if you don't put a person or a body or an institution to decide, it can't decide. And it passes up on a lot of things. And so we ask a lot of really good questions around cost. Or should a person that's 94 have a surgery or be hospitalized, or should we deal with end of life a different way? I don't know what the right answer is. But when we say, should the government make that decision, we say, oh, no, not the government. Okay. When we say, should a company make that decision? Oh, no, you can't trust for profit. Okay. Should a non-for-profit? Oh, no, they don't have the resources. All right. By definition, we are behaving a little like my family. Right? Where do you want to eat? I don't know. Well, who do you want to make that decision? And what we're saying is, I want to make the decision. Because that is a very personal decision about my mom, my dad, myself, my brother, and my sister. And while that's fine, what ends up happening is we have 250 million decisions, and by definition, it's inefficient, it's expensive, and it doesn't scale. And so my hypothesis is that we're going to have to do something about decision making, or we're going to have a blunt instrument intervene into healthcare. Because we've been talking about the unsustainable trend of the expense for so long that eventually there will be a breaking point. Because what's happening now is everybody says that the ecosystem is so large that I can't deal with it. So I'm going to grab data, I'm going to grab analytics, I'm going to grab labs, I'm going to grab insurance, I'm going to grab privacy, and everybody grabs a piece of it and says, I'm going to make it better. And sure enough, they do. And we make a huge advancements. But when the pieces come back together, the trend is inefficient, and it just continues to rise. And it continues to rise decade after decade after decade until the employers are totally dissatisfied because it's a big part of their P&L. And then the consumer is dissatisfied because now they're sharing in the expense. And it's one of the only things that every one of us expects world-class healthcare, and almost none of us have an understanding or an appreciation of how it should be paid, or if you want to pay anything at all. Because many of us believe that it's a given right, that it's not a privilege, and that's a fine way to think about it. But since we didn't let anyone make that decision hasn't been made. And now we're starting to get into tiers of healthcare where you have the limousine, the taxi, and the bus. And for some people, that's very distasteful because that's saying that one life is worth more than another life. And I'm not debating what the right answer is. I just want to stop pointing to all the problems. And I want to say, how are we going to make some of these decisions? What we're doing for kidney care, for better, for worse, we're not saying it is the answer, but we want to move forward, is we're saying we're not going to break it up into sub-pieces. We're going to grab this disease state, and we're going to take the whole thing. We're going to take the policy, we're going to take the insurance, we're going to take the clinical, we're going to take the IT, and we're going to do one disease across the entire continuum. This is Bernice. This is a normal, average dialysis patient. She's a real person, didn't know her kidneys was failing. So pre-dialysis, don't feel much. One day you start feeling sick. You go to the hospital. They tell you your kidneys are failing. Back to what Regina said, you don't process fluid. You don't process toxins. And so in essence, you would literally physically drown. And so you need to remove those toxins immediately. You, quote unquote, crash into dialysis. You have to go 4 hours, 3 times a week. Life changing. Your diet changes. Your job changes. Your transportation needs change. You're literally in shock into dialysis. And you say, how can that be that in this day and age, this happens? It's the equivalent of seeing cars on the freeway stopped all over the place because they ran out of gas. Because they did not have a monitor to tell them how much gas it was. That's the equivalent of that. So to take care of the disease state, what we're doing is we're saying you got to move backwards to go forwards. And so what does that mean? Is we're starting with predictive analytics. You see, the difficulty that we have in kidney is that there's 30 million people in the United States that suffer from kidney disease. 30 million people, of which only 120,000 or so will have their kidneys fail in a given year. And about 10 million will be in serious kidney, on the fence of needing care. And so finding the right person to give the right care at the right time is not easy. But we have now roughly 15 years of data, and we're doing a very good job at starting to find those patients. And if you can intervene early, then you can go back to what's at the heart of the conference here, holistic care. And so we are now grabbing Bernice, and we're not saying, what's your dialysis prescription look like? We're saying, let's talk about your diet. Let's talk about your home. We're going to Bernice's home and finding what medications are filled and which ones are not, and why there's pill confusion. We're literally finding in the refrigerator, literally, all the scripts that aren't being taken, but then she was embarrassed or confused to say that. And so we're taking the entire life back to where you started in this conference and saying, can we actually resolve all of the issues going on in this person? And we're going way, way beyond that. This is Lawrence. Lawrence is one of 30,000 patients that is now doing dialysis at home. Okay? What we said is, let's get patients as comfortable as possible without coming to a clinic. So this is a life-sustaining therapy that clears your blood. I think it's the most acute thing that we do outside the hospital. Now what we want to do is do it at home. So we've invested millions and millions of dollars on telehealth. We've invested tons of money on AI and remote monitoring. And what we want Lawrence and other people to say is, when I am home, I feel just as safe as when I'm in your clinic with all of the professional caregivers. That's what we're targeting. And we're not targeting that in 2050. We're targeting that in next 5 years. We think that we can move roughly a quarter to half of our population back home, but they do need all of the suites around it to surround the care so they feel the safety. And so the question for us is that enough? Can that get you the results that you want? And we think it is. And so we've got a couple of pilots, actually. This is, the government put out this. This is the U.S. renal information comparing dialysis cost and mortality. And the mortality is obviously benchmarked against other disease states, and the cost is over inflation. So we were literally 12% under inflation over that period of 10 years. And so in a world where we talk about advancements, and you say, okay, do you have the clinical and do you have the quality? The answer is yes. Our pilots are working. And we talked about, if you were in this conference, I don't know, Reggie, what is it, 5, 7 years ago, you would have been talking about ACOs. ACOs were the solution to everything, accountable care organizations. Kind of didn't know what they were, but it was just amazing. They were going to transform the world. They kind of came and went. You don't even hear anything about ACOs. And we had a renal ACO, and it actually worked because we were able to save a whole bunch of money and deliver better care when you did proactive care. But we ran into all sorts of architectural things from a policy perspective. How do you structure it? Who pays for it? What's the benchmark? If you were good before, all the normal things that you get into. And then we ended up getting stuck in the challenges. So where I want to leave you is, there's big things going on out there, there's exciting things going on, and we're doing a lot within our disease state. We are excited about the future. We're excited about what we're doing, and it would be crazy to let you think that renal is actually going to get resolved in the next 5 years. Because the same questions come back when I'm with my counterpart from Fresenius, and we have a unified voice in Washington, D.C. from a policy perspective. That actually simplifies it because you don't have fragmentation where every single provider comes in and has an opinion. We represent 75% of all patients with kidney failure in the United States. So that's helpful. But then what ends up happening is the government and other entities say, well, maybe that's too big. Maybe we don't want the healthcare to be for profit. What's enough profit? And so you start to get right back into it, and they say, maybe we want other entrants to participate. And then you go right back to getting stuck in the mud. So while we see a path, an exciting path, one that we are very eager, we are still working on the things that you are working on. I kind of go back and say, if you were going to think of today in a different way, which is my real goal for the opening, is Javier sat here in 1998 and he wanted to make a mark. My hypothesis is we need leaders. We need decision makers. We need people that are bold, that are risk takers, that bring us all along. But we have to make some kind of decision as to who's going to decide for us. Because yes, it will take time. Yes, it is challenging. And yes, it is well worth it. So I look back in history. 1964 was when there was the first election that started talking about Medicare. In 1965, Medicare came into being. Ever since then, healthcare has been a topic of an election. And in the last 5 elections, the mention of healthcare has escalated. And now it's in the top 3 issues of what Americans want. 92%, was what the USA Today quoted yesterday or the day before, 92% of Americans are dissatisfied with healthcare. And back to my hypothesis of the big amoeba, 50% of the people aren't open to change. Makes no sense. Literally, like, you're dissatisfied, but you want to keep it status quo. And so the question for the leaders in this room today, and where I want to leave you is, how will you make your mark? And I love the opening when you said, let's be critical thinkers and respectful. But I want to kind of switch that a bit, which is let's be critical thinkers and try to come up with an idea that will be helpful as well. Because I can tell you, poking holes at healthcare is pretty darn easy. Pointing to a solution and leading to a solution is not. But you will be sitting here in 2050 and 2060, I might not, and you will be saying, you will be hopefully invited to a beautiful building like this, and you'll say, I remember sitting in a room when I decided to make my mark. So I hope that that helps you for today, and have a great meeting. Thank you.
That was just a great speech. Thank you so much. I have a different way of framing the question for you that you raised, and that is not who, but what. And we have a system in which every stakeholder is very powerful, but we don't have a consumer-driven system. Consumers have no voice, and therefore we don't have real market-based system. Be nice to have that. market-based, meaning not something ideological, but giving people a voice in the shape of the system. But that was a great and inspiring talk, Javier. Thank you. I have a few questions for you. So, Davita did some things that are counter to the popular wisdom. Everybody agrees that healthcare is terribly fragmented, and that's one of the problems. It leads to diseconomies of scale and poor connectivity. And the answer was, and I think still is, ACOs coming out of DC. You hear Seema Verma talking about different models of ACOs, different kinds of cost sharing. Still a lot of physician-led ACOs, hospital-led ACOs. You took a very different approach. You focused on a disease. That's unusual. How did you come to think that was a better answer than everything for everybody led either by hospitals or by you or by docs?
Yeah, I don't think it was a brilliant conclusion, but rather one that we came about when you start to see how big the system is. And then you go, we know this population is unique because the chronic nature of it and the amount of comorbid conditions that they have, their complexity coupled with the fact that we have access to them makes it a very unique population. And so most ACOs and vehicles struggle to actually have contact with the patient because the sickest of the sick actually are very hard to get a hold of. The Medicare, Medicaid, the dual eligibles, the people that are living, homeless, et cetera, those are the people that are really costing the system a ton of money. And so we have, in essence, access, which makes it a very unique model where you could do a lot of things to a patient in a very effective way.
And the pieces that you have for comorbidities like depression, people on dialysis understandably are very depressed. Are they your pieces or do you outsource this? How do you make this model work?
We're doing all of them. So we don't have the solution for mental health is so tricky and so complex.
Right.
And so the question is, obviously from a depression perspective, is it set off because you're diseased and you're just trying to cope from, is it temporary or is it something broader? And so we have actually a couple people that are speaking in your panels today that are experimenting on different things from an analytics perspective, from a risk perspective, to having external experts being in our clinics. And so then the question is, can we have the patient stay in our clinic and then have specialists round in our clinic as opposed to the poor patient going all over and then having no connectivity in health records and starting from scratch every time. And so that way we can have everything in one screen. You come in, and no matter what the specialist, you get to see the whole person.
So what do you do about people who say, well, CHF, congestive heart failure, has 34 comorbidities. You couldn't possibly get them all. And they might say, and I'm sure they have, same thing to you, you can't cover all these comorbidities. What's the answer?
I would say you're right, but that doesn't mean you stop trying. And the other thing is that you can get 80%. And so at some point I'm saying, you're not going to be perfect. And you say, well, of course I'm not going to be perfect, but my gosh, I'm going to keep aspiring to do better.
Yeah.
And so it's like any athlete or anything that you do, you just keep at it and you try to resolve more problems.
And because you're focused, you have better ability to do that.
And we have 20 years of data on our patient population. And so it's not like, we're starting from scratch.
So you did another kind of counterintuitive thing. Fresenius is vertically integrated, makes its own machines. You guys don't. Why is that?
Yeah, well, I get that question a lot because they make money on machines. But we're a service company. Our soul is one of service. We are intending to be there for our patient, and we think that the rest of the world will gladly sell to us while Fresenius makes their own machines. If you are going to look at our company and you were to study our company, one of the things that you'd find is that we believe in that companies should have a personality, just like a human being. And we are very differential in our culture, very deliberate, We hire a lot of people from institutions like HBS because you are mission driven, you're very thoughtful, and you want your life to matter. And so we think that it's in the soul of our company, the culture is at the heart of it, and the heart of it is one of service, not one of manufacturing.
And can I go further than that? Davita's been so great to HBS and many similar schools around the country, schools of public health, and hired so many people for Davita. That's quite anomalous. And is it that you're looking for, if you were a Fresenius, you would have more technicians and fewer of these? What is it that drives you in this direction?
You know, my whole talk was about leadership and decision making. We're at the heart of it all. We have 70,000 caregivers, dietitians, social workers, nurses, doctors, and what do you need is you need leadership. And so we like Harvard, we like other institutions where you are being trained to be a leader of people in a very complex, most fragile time of someone's life. It requires the edge to understand the entire decision-making thing. And people don't follow just anyone when you're dealing with life and death situations. So it's a high bar, and we like what we get out of this institution.
Don't screw it up.
Yeah. And by the way, this is kind of a fun story for all the alum. I was announced as CEO, and within minutes, I received a call from the dean. And then I received a package from the school saying that they wanted to invest in me to make me a better CEO, and they brought me to a CEO course. And it was sort of a what I'd call speed dating on how to be a good CEO, and you leave, and it's just fascinating. It was a great gift, and again, a huge tribute to the school and how it treats its alum.
Yes. So another thing that Davita did is it kind of went off and bought its own primary care practice. That didn't work out so well. I've known Kent for many years. I knew that even as a student, he was interested in that. Tell me about this is not to say you did something you didn't succeed, but what are the generalizable business lessons of doing something that different?
That's how you get to be the godmother. You fail at this, but it's not to say you didn't succeed. Kind of is, I think. I don't know. Look, we bought a company called Healthcare Partners. It is a primary care company that was mainly in California. If you look at the model, it is exactly what you would want. It is a company that goes to an insurance company, a provider, the physician-led, that goes to an insurance company and says, let me take your lives, and I will do proactive healthcare to make so I will invest in taking care of the patient so that we actually intervene before they have something happen to them. Just like you would in anything that you do, you take your car to get maintenance, et cetera. You don't wait for it to break. And it was very inspirational. We bought it for $5 billion. We were very excited for the transformation of holistic care, proactive care. The company was totally jazzed. What we didn't understand is, number one, is you're in essence an insurance company and you had a very small market. So in insurance, size matters because the volatility of a population, so in a flu season or something like that in Southern California, we felt it pretty loudly. And then secondly, and probably more importantly, we underestimated the rate of change. We were so excited about the model. We said we'll move that model all over the country and happiness will come to the kingdom. And when you go to markets, there's a lot of markets where people don't want to change. It's overly progressive, or they see their economics being threatened, or there's a very powerful institution there, or there's a powerful health system, or there's a very powerful cardiology practice, and they don't want to be displaced, and so on and so forth. And so you're a change agent that is not welcomed in every location. And once we start seeing the rate of change, then we realized that this asset was in better hands in an insurance company that United Optum bought it for exactly what we paid for it after a lot of hard work. so it was disappointing, but we did learn a lot about population management, which we are applying now to our core patients.
And learnings were the difference in the stakeholders and their powers, and the difference in the cultures of both providers and patients.
Correct. And also understand the complexity of managing the whole person, right? I mean, it sounds great to move into this holistic care until you actually have to do it, which is, I'm not going to be just a football player. I'm going to be a general athlete. Like, we're great. That means you got to do a lot of things really well.
We used to have one of those, Tom Brady.
Yeah.
Good. Well, if that's complex, one can imagine how much more complex the broader ACO is. Not that dialysis is trivial, very hard to do, but you multiply that complexity and to the nth, it's really, really difficult to do. So what would you like to see coming out of schools that could help you further this great mission?
Look, I would love that minds like this enter policy. I think one of the things that's the most difficult is how do we think of our nation's healthcare system. When you look at the expense and when it happens, generally it happens on the backside of life. I would love for this population to start.
Don't look at me.
I'm looking at my son. He's going to change. I would really like to tackle, we talk about it and we talk about it and we talk about it, but there's very little being done in end of life.
Absolutely. Or more broadly, geriatric care.
Right. And then you see, I think the most challenging field right now is mental health. And there is no one that has a path that I know of. There's little micro models, and there's some that are actually speaking in the conference that are doing some really great work, getting some traction, but it is incredibly complicated, and there's been a lot of failed models around that and substance abuse. So those are the really big, heavy ones.
Great. Have some sum up points you'd like to make, Javier?
Some what, sorry?
Sum up points. You got 2 minutes.
Wow. No, I mean, look, what I want to tell you is when I look around and I see the youth in this room, I'm very jealous. We were sitting here talking around, and I said, I cannot believe that I'm in this room and that you're asking my opinion. It feels like yesterday when I was in your seat, just being excited to hit the world, and I was hoping to get a job where it mattered and I could make it count. And here I am, and having this amazing opportunity. And my classmates and the institution has been awesome at surrounding me. And so what I want to just leave you with today is be an agent of change. You've been at the mecca of thinking here. And I know that's a little arrogant on the Harvard, but it is just, Boston is really a cool place, super dynamic. And when you find yourself being critical of something, please focus on the solution because your brain, your investment, and your network are what's needed to change it.
Yeah. Analysis paralysis, time to go for some things that work.
That's right.
We welcome questions for the audience. For those of you who are masochists, I have 2 more panels at 11 and 1 in Baton. Love to see you. Olivia?
Sure. So the first question we have from the audience is, how do you balance the high cost of providing holistic care to patients while also ensuring dialysis is cost effective, as it is a significant part of government spend on healthcare?
Yeah, so we get a lot of what I'd call headlines that are provocative on our costs, but if you actually understand the disease, they're not fair. And so we're 1% of the population, but 6% of the cost. So by definition, you say, oh my gosh, it must be some kind of rogue, huge for-profit thing that's working. And the reality is, it's the reason why it's 6% is because they have to go 144 times a year. So it's the chronic nature of it that makes it so expensive. But if you look at it, on Medicare, our cost is roughly $250 per 4 hours of care. And so if you kind of say $75 an hour, I get my teeth cleaned for $85. I don't know if I'm getting taken, but
Bark.
it's $85, and it's a hygienist, not a doctor, not a dietitian, not life-sustaining therapy. And so I actually would go the opposite side and say, we are the single most efficient site of care that I know of in an acute setting. We're very proud of that. We think it's because of the actual expertise in one thing and not doing a lot of things. And so the real question there is, how much should you invest in holistic care? And how much is the government / other people willing to proactively invest rather than just kidney care? And we're in that journey now.
I would bet that holistic care saves money. It'll take years to prove that. But how much unnecessary care do people get, and how much care that could have averted much worse consequences do they not get because of the absence of holistic care?
Our patients spend around 11 days in the hospital a year. And we've taken that from roughly 15 days a year.
Absolutely.
And so I don't know if it was needed or unneeded, but it's avoidable.
Yeah, and at $4,000 a day, current cost per day of a hospital, in general, much more for a Medicare patient. It's an enormous amount of money.
Great, thank you so much. The next question is from Alexis. How do you work to connect to the broader ecosystem of healthcare? For example, you have so much information on patient data and are working on interesting analytics. How will you give that information, or given that this information affects patients not within your systems, like thinking about giving it to hospitals, an online calculator, et cetera?
Privacy is a very tricky thing, and we're working with the entire ecosystem. So there's these exchanges where we're a part of, where you send your data de-identified. We already participate, so we're in essence giving all that information. We are in a multi-year IT transformation where we're going to be probably one of the easiest providers to connect in the world. And so we're pretty excited to make information fluid.
Great, thank you. We've gotten a few questions on a similar vein, so I'll read the one from Charlotte. Davita has clearly done a great job of improving the experience of receiving dialysis for patients who need it. However, most would prefer not to need dialysis at all, no matter how well delivered that service may be. How can or might Davita get into the business of preventing the need for dialysis altogether?
Absolutely. So the thing that everybody would want on dialysis is a transplant. There's no way you can compete with the quality of life of having a transplant, because in essence you only need one kidney for it to work. Unfortunately, we have an organ shortage. We are investing in companies that are trying to make portable kidneys and/or organs that come from animals that go through all kinds of things to be plugged into the body. We're years away from it, but we're proactively investing in it.
So some countries like Spain have much higher rates of transplantations than we do. What's the difference?
There's two things. The U.S. has actually increased its organ supply in a meaningful way from 18,000 a year to 22,000 a year just recently. And it's because doctors are getting more comfortable with having a kidney that has hepatitis or HIV in it if the patient gets a waiver. So that's a personal decision. Would you rather have dialysis or have the potential risk of hepatitis? And so that's one. Number two is there's just more organ donation. And so this is literally...
Why is that?
I don't know. It's a good question.
Yeah.
And maybe something to tackle, which is, you know, when we go through end of life, et cetera, should we be more proactive in organ donation? So the technology works, the transplants work, we just need more organs.
Yep. And need to investigate how to get more organs. Olivia?
A question from Hari. Why can't a similar approach be implemented as a starting point for other disease states to limit reinventing the wheel? Is renal special in some of this operational approach?
I don't know if it's special or not, but we have 2 decades ahead of everyone else, right? So to my understanding, renal is the only disease state that's consolidated in the United States. So 2 providers have roughly 70% of all of the delivery system. And so what that's able to do is actually, we protocolized a lot of things. We formalized the science. We can tell who's a good doctor and who's lagging in their outcomes, and we manage that. And so we are now, though, targeting toward what I'd call personalized medicine, which sounds kind of sexy, but it actually is really amazing. So right now, if you think of medicine, it's protocol. And what that means is a little like if you were going to do an analogy, it's like going to the store and buying a shirt. You have small, medium, and large. And of course, you pick one, but it doesn't fit you perfectly. What we're trying to get to literally by next year is personalized protocols. So it identifies your body type with everything that you've done, how you reacted to that medication, and it's going to adjust to you. And we're already launching it, hopefully at the back end of this year.
That may be one of the problems of this field. We think personalized medicine sounds sexy. I don't think so. It's very important, but sexy, no.
Look, if you can have the machine customize your dosage.
Oh, no, it's very important. Very
It is.
important. Yeah.
It's sexy.
Okay, to you. Okay.
Here's a question from Roja. She has a question about how you view peritoneal dialysis as a means to deliver home dialysis care. Though outcomes between periodontal and hemodialysis are similar, what is hindering adoption as an equally effective home-based dialysis, and how can we better solve this?
For those of you not familiar with that, this is someone that obviously is familiar with the field. When you go home, you usually do, it's called PD, which is Baxter is the main supplier of PD. And so you, in essence, instead of having your blood go through your arm in and out in a center, you have a catheter that comes out of your belly and you plug in and out. And so the problem with PD is usually people only last around 2 years in it because your tummy can't handle it after that. And so the problem is not the entry, it's actually that almost everybody ends up back at the clinic. And so then over time, people just end up back in center. So we're educating it. Roughly, we think that 1 in 4 patients will end up starting in PD, but they will end up back in the center unless we are able to fix the actual peritonitis.
So Fresenius bought Next Stage and others to enable them to commercialize PD. Mm-hmm. Next Stage was so far ahead of it. How did you do this?
Well, Next Stage has got a different technology. So Next Stage went for what I'd call dialysis that's portal. So it's got a little machine, and everybody thought, man, we'll never need dialysis back in center because you can just plug in and carry your machine. What they failed to realize is that our patient population is very sick and quite old. And so while they want the convenience, if you see the needles that you have to stick in yourself, you'd have to stick 2 pretty thick needles every day or every other day because the dialysis, the machine is a lot slower flow, so you have to do it more often. And so when I saw the needle, I literally said, oh, this is going to be fantastic. And then I saw the needle and I said, I can't do it. And I know I'm chicken, but when I saw him, whoa, 2 big needles. And so that's what's deterring that modality from taking off.
I think in many cases of home care, there's such a terrible onus placed on the caregiver that perhaps isn't recognized by the very smart techie inventor of that technology.
Yeah, the analogy I use is homeschool. You might think that homeschool is better, but people say, I'm going to drop off my kid at school. I'll see you in a couple hours because I need to go do other stuff. So we find that a lot of the significant others and spouses literally say, look, my loved one has a lot of things going on. When I drop them off at dialysis, they have a community there. They take care of them. I can relax for a little bit and go do some things. So there is that, let's call it, guilt of a caregiver of a loved one.
Also the need for communities. So we have a case in my course on a company that focuses on seniors in Brazil. And they found that the greatest reason that they overuse the emergency room is loneliness. They view it as a place where they can gather. And so it's Brazil. So they built a party place in Sao Paulo, and they regularly hold parties and community sessions, and there is that component of healthcare that's frequently ignored.
God, I just went. I didn't know.
No kidding.
I could have partied at the ER. No.
Well, that's for the elderly. Yeah, you just went to Sao Paulo.
Yes, we have.
Yeah.
We have presence in Brazil.
Yeah, right. Okay.
Great, then that was our last question. So thank you so much for being here. We really enjoyed it. Let's do a round of
Thank you.
applause.